What I'll do over a period of next 8 to 10 minutes is just take you through some steps of Basilica. And I'm sure this is something which all of us are afraid of doing. So we have done a few lampoon. Personally, I don't have any disclosures because I have not done a Basilica, but we have done some lampoons, so we have some idea about the electrocautery and how it works. So this is just a small animation of Basilica. It's a bioprosthetic or native aortic scallop intentional laceration to prevent iatrogenic coronary artery obstruction. I think it's much easier to tell Basilica rather than the whole thing. So what we are trying to do is we are trying to tear the leaflet. The concept is once we put a valve in a valve or in a native valve, the leaflet is going to go and obstruct the coronary artery. So we are trying to artificially tear the valve, and that triangle which is formed helps in making sure that there is a circulation which keeps going on to the coronary. So once the tear has occurred, you can see the tear has happened, and the triangle which is formed is usually in front of the coronary. So if you compare a non-basilica valve with a basilica valve, you can clearly see that once there is a basilica which is there, the flow is maintained compared to a non-basilica valve. So that's the basic concept. So this is how the flow of talk will be, just to give you an idea of how it's performed and what are the precautions we need to take. The first question we need to start off is whether this particular bioprosthetic valve requires a basilica. And all of us are aware about the vivid classification. Fundamentally, we are looking at three things. One, the coronary ostia, where exactly it is, the STJ and the sinuses. And the vivid classification divides into type 1, 2, and 3. Basically, you look at the coronary ostia and we look at the STJ. If both are above, that is quite simple because you are not going to have any obstruction, so that is type 1. Type 2 is when one of them is lower, so the coronary is lower, but the STJ is still higher. If you have good sinuses, again, it's not an issue, but if you have a FA sinuses, it's going to be a problem. Type 3 is where both are below the upper end of the leaflet, so the STJ and coronary both are lower down. But of course, here again, if you have good diameter and the sinuses are wide and open, again the flow continues. But if the sinuses are effaced or the STJ is closed, then we are going to have some trouble. So based on that, we have the algorithm where if it's type 1, so if it's type 1, as we mentioned, we just go ahead with a conventional TAVR. Again, type 2A, we go ahead with a conventional TAVR. If it is a type 3A, again, we go ahead with a conventional TAVR. In all the other aspects, then we start looking at the other things. That's the VTC diameter, that is the valve to the coronary diameter, and we look at the valve to the STJ diameter. Anything less than 4 mm, we consider a basilica before we go ahead with it. The alternative is a chimney stent, but the overall outcomes are not good, so the thought process is to go with basilica whenever possible. Now, there are certain analysis which we do. If angiogram is available readily, then we do angiographic analysis in addition to the CT analysis. What are we looking at in angiography? So if you have a bioprosthetic valve, we try to come to an angle where at least two posts are overlapping each other, and this is called the side view or the 1-2 view, and try to see where exactly the coronary is arising, and you can also see its relation with the STJ. So this will give you a relatively good idea about what you are going to face when you are actually putting in a TAVR valve. The most important aspect of analysis of basilica, or for any valve-in-valve for that matter, is the CT analysis. This is what we were mentioning about the VTC. That is, you put a virtual valve there and then try to see what is the distance to the coronary, both the right as well as the left, and also the VT STJ. So you are looking at the valve distance to the STJ. Generally, VTC less than 4 is considered dangerous. VT STJ is not very clear what the cutoff number should be, but again, less than 4 is considered to be slightly risky compared to somebody who has more than 4. Now, we also try to analyze what are the views which we are going to do when we are going to do basilica. So when we are looking at a coronary, we are looking at what is called the front view. So it's exactly opposite to the post. And the other is a side view where something like a cusp overlap, where we are trying to overlap two posts and then isolating one post. That will be the side view, which we just showed you on angiography, to know exactly what is the height from the coronary. Now the same thing can be done on a three-dimensional analysis. So you try to make sure both for the left as well as the right, whichever leaflet you want to do basilica, you try to find out the front view and the side view, so that when you go into the cath lab, you have to just replicate those particular views. Now this is one aspect of CT analysis, but there are certain other things which we need to look into. One is the aspect of ostial eccentricity. So though the post might appear to be opposite to the coronary ostia might be slightly eccentric. Then you lose the advantage because the lacerated tip gap which you have just produced, that is beside the coronary ostia. So the idea behind doing basilica is then defeated. Similarly, we should also know what is the valve which is being implanted, and there can be some confounders. Like if you have a balloon expandable valve, we can have flaring. If we have a self-expandable valve, depending upon the depth, the place where exactly the leaflet comes can vary. And also we have the canting where there can be a movement of the valve, which you can reproduce either for a balloon expandable or a self-expandable. And that can again change the orientation of the leaflet tear compared to the coronary ostia. So all these aspects we need to look into before we actually go ahead with the basilica procedure. So a huge list of procedural points, right from access to snare system positioning. We'll just go through some of them. Important is to have an equipment checklist, have a paper in place, keep everything ready, and make sure that we have all these things. One of the important hardware which we need to have is the astato wire. Basically, the advantage of astato wire is it is a single core design. So if we give an electric current at the other end, it goes up to the tip, which doesn't happen with many of the other wires. And it also has a coating which can be just denuded so that electricity can be given exactly, the electrocautery can be given exactly at that particular point. So we have certain systems, some names which we should know. So traversal system is basically to traverse the leaflet. So the outermost is the 8 French guide. Inside that we have a IM catheter. Inside the IM catheter is the piggyback. We don't have piggyback available here, so we can use just a fine cross. And inside that is the astato wire. So this is the whole traversal system to actually do the basilica. The next is the lead snare positioning. So usually, as was mentioned by the previous speaker also, the snare diameter is generally the diameter of the LVOT, and we should make sure that it is parallel. So whichever way the wire is going, the snare has to be exactly parallel there so that there is, it doesn't move beside that particular snare. This is called the attack angle, which this is the place where we spoke about the front view and the side view. And the catheter needs to point exactly like this so that you get the electrocautery exactly at the base of the leaflet and not somewhere else. So any change in the orientation, depth, or the attack angle can again cause failure of that basilica procedure. So once you have traversed, then of course you catch it with the snare and you pull it back into the guide catheter which has been taken from the opposite groin. Now you don't pull the whole thing outside, because the next step is to make the V with which you are going to actually cause electrocautery of the particular wire. So this is how you make the V. Just do some denudation, then press it hard and then turn it on both sides. And so the internal side is going to cause electrocautery, whereas the outer side is safe because the coating is still present. Now why do we do all these things? It is basically to prevent dispersion and make sure that exactly at that point the electrocautery is delivered. So the denudation on inner surface, the piggyback both sides so that again there is no electrocautery dispersion, and you use 5% dextrose to clear the blood in that particular place. So this is the way it appears. Looks very complicated, but If it's done in a proper manner, it's quite comfortable to do it. And you, of course, try to keep some torquer there to make sure that the wires don't move once you have decided the place where the V should be formed. And then, of course, once you are in position, then you pull back that particular V, and then it causes the electrocautery tear. Now, the important thing here is to remember that it is a controlled tear which is being produced, and it's not a laceration. If you just tear it without the electrocautery being delivered properly, then it's going to tear the leaflet and can produce torrential AR and make the patient hemodynamically unstable. Whereas when you tear it with electrocautery, you still get some time to go ahead and then put the TAVR valve. So this is an angiographic clip to show you the same thing. So this is the bioprosthetic valve, the snare is there. The astato wire has gone across the leaflet. It has been snared by the gooseneck snare, pulled into the guide catheter. Once this is done, a V is formed outside on the table, and then the V is pulled across the leaflet to make sure that tear is done from the base to the tip. And then, of course, rest of the thing is just like a routine VIV TAVR, a balloon dilatation or a fracture, and then put a TAVR and decide about a fracture. Now, what are the contraindications where you should not do a basilica? If you already have a completely effaced sinus, even if you have done a basilica, there may not be any place for the blood to go into the coronary. So there is no advantage of doing a basilica. So again, that's the reason why pre-op CT analysis is extremely important. Unusually calcified leaflets is again a problem. There have been some studies where balloon assisted has been done. So you go ahead with the traversal system, then a small 4 to 5 mm balloon you dilate, and then do the basilica, but still those studies are going on. Extremely low coronary heights. If the triangle is, in spite of doing a basilica, if the triangle goes above the coronary height, again, it may not be useful. And of course, the normal routine contraindications like thrombus, mobile, structures on leaflet, infective endocarditis, that's the reason why all the VIV, we should have a baseline T to make sure there is no contraindication for the VIV per se. What are the complications? Of course, we are tearing the valve, so there is a risk of AR and hemodynamic instability. Injury to surrounding structures, again, understanding of what are the structures around is important. At the same time, we also, this is the place where that concept of side view and frontal view comes. Unless we are sure that we are in the right place, we are not supposed to go ahead, otherwise it might enter into one of the adjacent structures. And arrhythmias, again, because of the use of electrocautery. So finally, a word about shortcut. So this is made the abbreviated the learning curve, and it's made things easy. It's not yet available in our country. I think once this comes, our usage of leaflet modifying strategies before VIV is going to go up. This is the initial paper by Dr. Dan DeVere about the shortcut procedure where the leaflet is cut and the same thing similar to basilica is performed. Just a short video to show how it works. You can see that the device is made to land on the leaflet, and then there is a splitting element which is activated, which goes towards the leaflet, and between the outer element and the splitting element, the whole thing is pulled back, and once it's pulled back, it causes a controlled tear over the leaflet. Once it's done, of course, similar to basilica, the coronary flow is established. So, ladies and gentlemen, the take-home message from this talk would be that coronary obstruction in VIV is a life-threatening complication. Careful pre-procedure CT analysis helps in identifying patients who need a basilica. Basilica is a complex procedure involving multiple steps. Guidance from those who have already done this procedure is paramount. Always have a proctor there initially when we are doing the initial basilica, and newer devices like shortcut can help in reducing the learning curve of these procedures. Thank you so much.